domestic violence exams are actually our favorite exams. We love them. The nurses all, once they've figured out how to do them, we love taking care of the patients. So in New Mexico, and I know that there's tribal laws here as well, but New Mexico, you do not mandatory report domestic violence.
All cases of suspected abuse and neglect with domestic violence must be reported to authorities. The mandatory reporting policy is in Navajo Area Indian Health Service, and it says all medical staff are mandated reporters for domestic violence and sexual assault abuse allegations when domestic violence has occurred. Always notify law enforcement officials, even if the patient does not want to press charges.
Only if a child is involved, right? If a child was harmed during a domestic violence, then you're going to want to have the patient call. So we have them call the child services, and we enable them, empower them to say, look, you need to make sure that that's reported, because if you do not protect your child, you could lose custody, right? One of the ways an offender controls their victim is to say, you're a bad mom, I'm going to have COFD, take away the kid, you've done this drug, or you've done this bad thing, and they're always making them feel guilty and ashamed, and they're not a good enough mom, therefore they're going to lose their child. So if the child was harmed, CYFD could be wanting to make sure the child is safe because they just care about that child, right? So we're going to empower them, tell them, no, you need to report it. And so we'll sit there with them and let them report it. We do know that domestic violence in the home is one of the worst things a child can experience. It is worse than anything, including actual being hurt and actual sex abuse in the home. It's the greatest predictor that they're going to grow up to be a victim or an offender. So we want to stop domestic violence. It affects everyone. And so it is a community issue. The CDC has determined it as a community health issue as well. So it needs to be trained. It needs to be talked about so that medical providers can be comfortable. It's hard. It's not easy to talk to somebody about what can be very intimate violence, but we have to be able to do that. In crossing a divide, it's interesting, crossing a divide in a professional setting, but when I see somebody in Starbucks, I'm like, and I don't feel like I'm able to go and talk, excuse me, ma'am, did that guy just do that to you? Right? Where at work, I'm like, okay, I see this, I see that, and let us talk about it. But professionally, at least in our professional setting, we should be able to talk to people about it. SANES, we speak very plainly, very upfront about sexual violence. You guys can help reach somebody who may need help. They may have never disclosed their abuse before. And if the way you guys respond to a victim of domestic violence could mean the world, okay? You guys have that ability. We have lots of patients that we see. I have had patients sit in my lectures and classes, and I have not recognized them, right? We have a lot of patients. We have to forget them in order to survive, right? But they remember us. They remember us when we're good. They remember us when we're bad. But they really remember us when we're good. You know, so you can be a voice in the darkness. And safety and psychosocial health are important, right? So at Albuquerque, prompt, confidential, objective, medical, plus forensic treatment by specialized nurses. We were formed to obtain a rape kit to get forensic evidence of a victim of a crime, of sexual violence or domestic violence, by use of cameras and our charting and swabs. But what we really, really focus on is the medical care. Back in Albuquerque, and I don't know if you know about the New Mexico backlog of rape kits. It was truly horrible in Albuquerque. I knew it when I learned it, because I was all like, you know, at the beginning, you're all, I know this is great. Everybody's going to get the rape kit done. And no, nobody was getting their kits being processed. So I would be literally cynical going, there's another one for the black hole. But it just caused us to focus even more on our medical care, because everyone deserves to be treated. And get forensic treatment. They shouldn't have to die to get good forensics, right? So we are absolutely free. Oh my gosh, and in this nursing, in this medical world, where can you say you get free service of 2 hours with a medical provider? Hello? Are we nurses medical providers? Yeah, Yes, we are. We're not the provider, but we are providers of medical care. And I do definitely work off of nursing diagnoses. Remember those things? Ew. I use that in court, actually. People are like, but you're just a nurse, you can't diagnose. And I'm like, no, but we have this thing called a nursing diagnosis. So somebody comes to me with a specific complaint. How do I treat them because of it? They're like, oh. I was like, oh, I got to go thank my instructors. I hated those things. I know. But it's true. It is true. The nursing diagnosis is effective. So our place is safe, it's quiet, it's non-rushed, and even if a SANE unit is in a hospital, it's supposed to be that way, right? One-to-one, they have locked rooms, nobody's going to be coming in on you. And the services are always presented as options so that the patient has that control to say yes or no to each and every service that we give. We are culturally safe. We work very hard on that. We see the LGBTQ plus and Native communities, whoever comes to us, we want to be safe for them. So however they gender present as well. And no police report is needed. If police need to be brought in, then we can assist them with that. So we're going to screen these victims of IPV carefully. What we find with IPV, domestic violence patients, we have body injuries. Some are very minor looking, but they can have really terrible other aspects of the domestic violence. And then there can be sexual assault, which will have no body injury, but if it's domestic violence with sexual assault, those typically are our most violent cases, and we will go sometimes to the hospital to take care of them. And I'm going to say that I have taken care of far too many people in the ICU who've been fully vented because they're dying. Okay, their brain dying, their brain death, they're going to be donating, and we've had them flown, because I live in Albuquerque, the Trauma One Center is there. We've had them shipped from all over Crown Point and all over the state. It's terrible, and you just go, they break your heart. They break your heart. And sometimes when we're doing a medical exam on someone who's dying, you're like, this is to remember them and to honor them and to take their statements. Okay, so strangled. So we are going to take care of a patient with IPV, domestic violence, anyway, but we're going to specifically ask if they were strangled. And when we ask strangled, what do they normally say? What do they normally say? Choked. Fine. We're going to say, he choked me. I'm going to use quotes. And then I'm going to say, and I'm going to say, actually, did hands go on your neck? Did he put hands on your throat? Anything on your neck? You know, did he grab you by the shirt? Did you get choked? That's fine. And I'm going to write strangulation because I know that's medically a term, but choked, that's fine. I'm not going to correct them. I'm just going to let them know how dangerous it is. So the wounds may not be visible at first or at all. We understand this, right? We understand that really terrible things can happen to the body and you have like no injury. Trauma nurse here, I've seen people fly from cars and they're like, well, my thigh really hurts. And I'm looking at the thigh and I tell the doctor, sure enough, there's a fracture in that femur, right? But do I see anything? No. They actually don't even have any bruising yet. And those will be deep and when they do come. Are they agitated? Do they need medical attention? Sometimes with us, so in Albuquerque, we have a lot of hospitals and a lot of IPV victims do not want to go to the hospital. Part of it is they're afraid that the police are going to show up and their offender's going to get arrested. They're not going to have that choice. They're afraid of that. Sometimes they're told this, that if you go, they're going to arrest me, and they're not necessarily ready. We did have a patient, she said, my sister forced me, that she called the police. I wasn't ready. I just wasn't ready. And when we're thinking about what are the dynamics around sexual assault and domestic violence, it's power and control. It's power and control. One is an acute episode. Maybe it's somebody who's not in a relationship or peripheral, like a sexual assault offender. That's an acute exam. Then the domestic violence is that chronic condition, right? It could just be a week, or it could be 32 years, 40 years. We had a lady who came in, this one, poor thing. She was black and blue right here. She had some cuts, and I'm like, she was so mad. She's like, I thought we were done with the violence. I stayed with him, but he comes home with a bottle of Viagra. And she said, what are you going to do with that? And you think about an abuser who has Viagra, and this poor woman hasn't had sex in 5 years. She thought they were done, and he shows up with Viagra and a hard-on, and she's like, no, 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 no. And he beat her with the Viagra bottle. I remember that clearly, and she's like, that's it, I'm out. I tried. But she was really pissed.